Welcome, everybody, to session 7 of our 8-part series of incorporating 988 Continuum of Care. Sandri Kramer from Didi Hirsh presenting today. She's the Director of Community Relations for Didi Hirsh's Suicide Prevention Center. Really excited. She's got a great presentation for you.
I'm happy to share all the work that Didi Hirsh has been doing in the realm of before, but also after the launch of 988 and the impact it has had on us. I have worked in the crisis center and suicide prevention field for over 25 years. I wanted to call this presentation Healing Crisis Care Systems and the Promise of 988 and how I feel about that and why that's the case. Immediate and short-term goal of 988 is basically a strengthened and expanded lifeline infrastructure, right? 988 Suicide and Crisis Lifeline, thereby helping many more people in need than ever before. But the long-term vision involves a robust system that provides the crisis care needed anywhere in the country, right? Because the reality is that with a system that is effectively resourced and promoted, we'll be able to do a lot of things. A 90-day crisis line that is effectively resourced and promoted will be able, first and foremost, and I think really and truly this is the most important part, and stigma towards those seeking or accessing mental health. And I'm going to talk about that a little bit in my presentation today. I believe that it can reduce use of law enforcement, public health, and other public safety resources, as well as meet the growing need for crisis intervention at scale, right? Because there's layers. We're not always going to be up here when we're in a crisis. Sometimes we're here, sometimes we're lower. And our needs are different during different times. And then finally, reduce healthcare spending. If we are able to provide more preventative care and allow people to do this via a telephone or via a chat or text, obviously that is going to have a huge impact on the amount of money that we spend on healthcare, right? So for the entire network, since the launch of 988, more than 300,000 calls, texts, and chats have come in each month. And if we compare December 2022 with December 2021, calls answered, okay, this is calls answered, so not just calls received, increased by 48%. Chats answered increased by 263%, and texts answered increased by a staggering 145%. The reason for those latter two really is because additional funding has allowed Vibrant, who runs the administration of the 988 network, plus the additional state funding that has become available, there's simply a lot more funding available. That clearly has made all the difference in the world. In addition to that, when you're looking at text increase, is because actually that wasn't really advertised. So texting wasn't advertised at all, and chat only minimally. And that is probably why we're seeing such large increases there. For us, for Didi Hirsh, we compare 2022 to 2021, we have seen an increase of almost 40% in our number of contacts. So this includes calls, chats, and texts, right? And that's a lot. And to help us manage those growing demands, we have gone from 132 paid staff a year ago to 255 as of April this year. That has also meant, so almost double, but we certainly have more than doubled our training team staff, because what we decided to do is to really and make sure that we have enough butts in the seats, right, to answer all of these calls and chats and texts. Um, we needed to step up the number of training classes. And the training classes that our crisis line training team puts out are very resource heavy, but extremely important. So in order for us to really increase our capacity, we really needed to first focus on increase the number of trainings that we offer. And that has been very significant. Now, I also want to note here that Didi Hirsh is a blended center when it comes to staff versus volunteers. We have both. Primarily in our history, and I have been with the Suicide Prevention Center for um, a very long time, and I wanted to note even before we became part of Didi Hirsh. I'm sorry, I lost my train of thought. Uh, and it was almost purely volunteer based. I myself started as a volunteer, just having passion for the work, right? And that's sort of the extent of where we were and where we are now. But you can see that it's shifting more towards paid staff versus volunteer staff. How can we heal this crisis care system, and what is it that we need to look at? I saw this at a network updates from Lifeline and SAMHSA in Portland in April this year at the annual Suicidology Conference. And I really liked the way this was represented. So I wanted just to go over with you a little bit on what this even means. So the behavioral health continuum, the idea, this actually was based on information, um, um, an advisory group of SAMHSA, focused on the importance of peer support in all mental health and crisis services, right? And that needed to also include both mental health and substance use crises. And what is it that they're looking for? And so I really like that because it kind of helped us focus. We are using this particular model, this graphic in LA County for our strategic plan on suicide prevention to really kind of hone in on what the gaps are that we need to concentrate on. So for the prevention and early intervention piece, here are the key components of that. We need good public awareness, right? To even talk about not just the continuum, not just, what is mental health, what is suicide prevention, what are substance use disorders. It really is more about an acceptance that this impacts all of us and that all of us therefore can play a role in helping this and managing this. Um, Part of prevention and early intervention services also it means that we need to invest in recovery services in our communities. Want to make sure that there's some universal screening available to any service provider and any individual, kind of knowing what to do to help do an intervention when an intervention is needed, right? I can tell you that in the many years that I've done this kind of work, we on in crisis centers, the idea used to be, well, we need clinicians, we need professional mental health care providers to really do this work. And it turns out that actually the opposite is true because crisis work is very different from mental health work or clinical work. And sometimes the clinicians that came to our center to offer their volunteer services um, didn't make it through the training because it was very different from the work that they're used to doing. So this is also, I believe, why we hear so often that we need to approach suicide prevention and crisis care through a public health lens. I think it's wider than that, but what I like about this perspective is that it gives everybody the opportunity to take personal responsibility to not just help ourselves, but to help others and to be mindful of that and not to be afraid to be nosy. right? But we need to give people the tools to be able to do that. Hence, this idea of screening and brief interventions. There's got to be a focus on harm reduction. So this has to do with safe storage of firearms, securing bridges and structures to make it more difficult for people to access those, to educating our pharmacists and primary care and physicians to be mindful of certain medication that could be dangerous if taken in an overdose forms, things like that, right? So that's what harm reduction is about. And then finally, we need to be able to make it really easy for people to access care and not have like super long wait times, which for Didi Hirsh, for example, some of our services, which are Medi-Cal Medicare based, there are long wait times and we need more urgent care, drop-in, respite center, whatever it takes, right? So that's part of prevention and early intervention. Then if we look at the bottom part there, the behavioral health crisis services, this is crisis services specific. Now we're looking at investing in needing suicide and crisis lifeline, mobile crisis teams, stabilization centers, peer respite centers, making sure that we work with first responders and embedding mental health into that, and also having withdrawal management like detox centers and things like that. And then the final piece here is the recovery support services that are needed after all of that, right? After we've intervened in a crisis. So look at this system as here's what we can do to prevent and to also put in early intervention. If we are not able to prevent something, then we need to deal with the crisis at hand. But then we need solid aftercare, right? Which is why it's sort of this continuum. It's a circle. So after the crisis gets addressed, we need solid recovery support services. We need team-based wraparound care, outpatient services, assertive, I like that word, community treatment, residential services. Didi Hirsh has a couple of crisis residential facilities, and also hospital and intensive inpatient services. Okay, so this just gives you an idea of what we're trying to do, or what the nation is trying to do. This is one of the models that is out there to really look at the continuum of crisis care. So here are the primary points of the guidelines for crisis care systems. Okay, addressing the recovery needs, significant role for peers, and this is, I love this, and this is somewhat new. This is definitely not something that has been fully incorporated or embraced, I should say, by the crisis center community until I want to say maybe in the last 7 to 8 years or something like that. And now there is a hyper focus on it, which is great. We need trauma-informed care. We need to focus on care that is suicide saver or focusing on zero suicide, the zero suicide initiative. And so in California, there is the Striving for Zero initiative, and a number of counties are working towards that and getting technical assistance to help address some of these things. We need safety and security for people in crisis. And finally, we need crisis response partnerships with law enforcement, dispatch, and emergency medical services. Okay, this is just an intro to, now I'm going to talk about what it is that we have discovered in LA County. So this is very specific to LA County in a way, but because Didi Hirsh services a large patch of Southern California, it would be other areas as well where these gaps exist. So first of all, we need to close the gap between services provided by 911, by 988, by 211, and in LA County, it's the Department of Mental Health's access line. Okay, so what do those collaborations look like? Well, for us, in February of 2021, after many, and I cannot stress this enough, many years of preparations. This has actually been my baby. I started to um, try and get police departments interested in doing this with us over 15 years ago now. Um, but it finally happened, and we launched this in February 2021, a 911 diversion program. So far, over 3,500 calls have been diverted to us. And of all the successfully diverted calls, only 3% necessitated a facilitated intervention, and 14% needed further in person care. I was just going to give you the highlights of this, but I realized we have more time. So I'm going to do a little bit of a deeper dive into what this looks like. For our collaboration with DMH, that's Department of Mental Health Access, we are currently working on several pilots to do a better coordination of mobile response, and more on that a little bit later. First, what I want to share with you, our flow chart. I know this is not easy to read, so I'm going to go into a little bit more detail in the next few slides to give you a sense of what this even looks like, right? But at least this will give you an idea that we go from people calling 911 and through what route they may be able to end up with us with 988, and we manage it over there, although a big part of it is also follow up. This route over here indicates when at the dispatch level, they determine, no, we need to involve law enforcement. And then ideally, they get one of their co-responder teams. And this is within LAPD, this is called MEU, which is a mental evaluation unit. They have several SMART teams, and those are officers paired with clinicians that go out. But currently, they're only able to handle about a third of all the requests that come in for these co-responder teams. This has partly to do with, as you all are aware, we've had a nationwide call for a decrease in funding for police services, so that was part of it. That has since been corrected, at least in LA City for the LAPD, but there is a workforce shortage of clinicians wanting to do this work. So it's still going to take them some time to build up their capacity. And this kind of shows you how important these collaborations between 911 and 988 are. So in more detail, as promised, this is what it looks like. So call comes into 911. LAPD dispatch, this is what they're going to look at. If the caller if the call includes any of these criteria, or the caller has any of these issues, then the call does not become eligible for diversion. And these are the circumstances. If they need medical attention, typically it goes to LA Fire and they send ambulance services. If a person is on a structure or a bridge in a public area, right, where there is not just potential dangers to the public, but also there could be dangers inherent to a diversion of onlookers as well. Or if a person has a weapon, right, so traditionally, most often this would be a firearm, could also be a knife, and they are in public and others are there. Or if they have a weapon, they're not necessarily in public, but there are other people present. Okay, so in all of these circumstances, basically what we're talking about is either a medical or a public safety emergency, right? And that is when the call stays with LAPD, and they're going to send in a co-responder team if a co-responder team is available. If none of these things are the case, and I want to highlight one thing here. If you look at number 4, and it says a person has a weapon, is inside a residence or building, and with others present, right? If you take away the no others are present, that means that we can have high risk calls, somebody with a gun, who would be eligible to be diverted over to the 988 crisis line. That was a little hard initially for our 911 dispatchers to accept until they recognized and were taught about disengagement policies. And they learned that a lot of times when a police unit does go out and does respond to a situation like this, and the person does not want to engage with them, when they determine nobody else is at risk, they step away from that situation. And so now we're left with a person with a gun or a knife or what have you, and they're not getting any kind of help when they could have received crisis counseling support through the 988 hotline, right? So that was really important for people to fully understand in order for this to be successful. When they determine it is eligible to be sent over to us, we get some important information like an incident number, the caller's phone number, location, address if they have it, and their name, and just any essential call details. This is just an idea. This next slide is an idea of what the 911 dispatcher might say to the caller. So they're not just going to blind transfer it to us, right? They're going to let the caller know, I'm going to connect you with somebody who may be able to help you and kind of explain that. When a call comes in for us, we have a dedicated line for that so that we know this is 911, LAPD 911, with a person in crisis on the phone. It has highest priority because there's going to be a dispatcher waiting along with the caller, right? So that is one of the things that we had to put into place and will become a very important part as we're working on best practices and other types of templates for our state, for California, to do 911 to 988 diversion. This piece is very important to understand that it's got to be a priority, and it has to be a warm transfer, and it cannot just be a cold transfer. And then so when we get it, we handle it like any other call that we handle. And that means that we want to offer follow-up. We just have an assumption, even if the caller tells us they're not suicidal, this is a higher risk call because they reached out to 911 initially. So we're always going to offer follow-up services. And we also built in, as you can see there, a way to connect back to 911 dispatch if it turns out, you know what, there is an immediate safety concern, this person needs some help. So that's all part of the system. Give you a couple of stories that kind of highlight how important these kind of calls can be. So here's the first one. I'm just going to read it to you. So this caller, L, called 911 feeling threatened by unknown individuals who were coming into her home and destroying her property whenever she wasn't there. And this is at least what she believed and what she reported. She felt nobody believed her. She'd been calling 911 with some regularity, I believe. And she's having a hard time controlling her anxiety and suicidal thoughts because of that. We get this call, and it turned out that for Elle, having a crisis counselor listen to her without judgment really helped calm her down, and she agreed to a follow-up call. And the neat thing was that at the time of the follow-up call, she was able to engage in safety assessment and planning, and she accepted resources, and she was especially grateful for having the Lifeline number. And so now it would be really easy, but when we first launched this was still the longer 1-800 number, right? So that she could share that with her 21-year-old son, because she realized that he was significantly impacted and worried about her all the time. And this was one way that he could get some support in order to support her. And then this other one was really poignant because it came a week after a national incident that was very similar. This was a dad who called 911 about his 6-year-old little girl who was very upset, who couldn't stop crying and kept saying things like she just wished she were dead. He was unable to calm her down and was very, very worried, and he did not know what else to do. So he called 911. So that call was diverted to us. Dad was connected with a crisis counselor who, validated his feelings and the situation that he was in, certainly empathized with him, and then asked if she could maybe speak to the daughter. Now, you never know how that goes when it's a very young child like this, but she was able to engage with her and did some breathing exercises, which significantly calmed her down and ultimately de-escalated the crisis. Dad was very grateful and glad to accept further resources for her and for the entire family, right? This came, like I said, a week after a national incident where a 9-year-old little girl, similar situation, police, so the parents called 911, police showed up, and she was handcuffed and put in the back of a police car, completely distraught. Everybody was very upset, and it made the national news. And that was clearly not the way to handle an emotional health crisis, right, for a child. And this was so much better an outcome, and that can be accomplished with close partnerships between 911 and 988. So threw that in there for you all to have a little bit of an idea of what it is that we're able to do, and we're still growing and adjusting this program. So going back to the gaps that need closing in crisis response. Well, the second thing that we don't have and we really need to have, and this is for us, for the 988 Center, right, is that we need to have access to real-time data. So yes, we're building out more mobile response team. I'm saying we, that means not us directly, but the county is doing that. And they really want to make sure that these teams can respond in a reasonable amount of time. And if they need to take this person to urgent care, stabilization, detox, you name it, then we need to know, where are their beds available? None of this yet exists in a real-time database. Our county Department of Mental Health is absolutely working on this, and we are involved in like I said, in several pilots to facilitate it, which I'll talk about in just a minute. But without knowing how long if any team is available, how long it will take to respond. And keep in mind, LA County, we have almost 10 million people in our county alone. It's extremely important that we know if a person can stay safe until somebody can respond to them. But if we don't know what the response time is, then then we can't really help determine that. And because of that, in the past, and still most of the time, what we are our only solution to this is for us or for the caller themselves to call 911, which is the opposite of what you want. But at least then we know that there's going to be a more urgent response, right? So it's a gap that needs closing, and one that the county is working on. 988 Center should be able to dispatch mobile response teams. We have not been able to do that in our past, but that is one of the pilots we're currently working on. And it's really through a massive effort within our county called Alternative Crisis Response. Aspiration for ACR, Alternative Crisis Response, in our county is this: individuals experiencing mental health crisis in LA County are treated quickly, effectively, and with empathy, and I want to add to that, and respect, at the least restrictive level of care to meet their short and long-term needs in the mental health system as appropriate, so that they can remain in their community. Okay, this is a mouthful, but in essence, what this is saying is that we don't don't want to necessarily put people on involuntary holds or have them be in an emergency department waiting room, and then ultimately maybe be seen for just a little bit and be sent on their ways. There's so many things wrong with the system when there's so many gaps that fall into that, right? And that is what ACR is all about. It's ambitious. As I said, there's almost 10 million people here. But as I also said in the very beginning of my presentation, I have never been more optimistic about the potential and the promise of being able to heal our crisis care system, and response is a big part of that. The county is building out some of their mobile response teams. Again, workforce challenges are there, but they are now working with contractors who are establishing mobile crisis outreach teams. Those teams are made up of a clinician and a peer person. That is not the traditional model of PMRT, which is housed within the Department of Mental Health. Those are clinicians who respond. However, they are changing that model as well and adding peers into that as well. So they are together combining these into a new acronym, because we all love acronyms, called FITS, and these are field intervention teams. So far, we have done a number of trainings between the Access Center. Access helpline for DMH is how people access these teams. So they have to call them. Again, 988, and we're not necessarily able to do that. What we're doing right now is doing these warm handovers with them. And we are thus far in our pilot that the trainings have been established, and we're doing these warm handovers. Again, what is still missing is the real-time data. We still need that. And ultimately, the idea is for us to do direct dispatch so that we don't need to go through our Department of Mental Health and can do this ourselves. And the only way we can do it is, again, if we have real-time data access. And then eventually, and I think this is really important for everybody to remember with 988, is that we service really large areas. And there's fantastic work being done in certain cities and in certain counties, but there's so many more areas that we have to cover. And ultimately, that is a goal of all the California 988 centers, is to form a solid network where we know where we can send mobile crisis response and how to do that, right? Something to still work on. All right, going back to our gaps. Ultimately, we don't want to just dispatch mobile response, but we also want to dispatch co-responder teams and even medical transport, right? So this is what the county is currently looking at. I want to give you an example. If you call from any unincorporated area in LA County to 911, you're going to most likely get our sheriff's department. And the sheriff's department has something called MET, which is mental evaluation team, and they have a triage desk. And so if any of the 23 stations within the sheriff's department get a phone call on 911 that involves a mental health crisis, it goes over to the triage desk. And then from there, they determine what they can do and what needs to happen, right? Currently, what we need to do as 988 is we would love to be able to have direct access to MET, but instead we need to call the 911, local 911 line if we need help like that for a caller who needs that level of support. And so ultimately, that is something that we really want to do. And another thing that would be really helpful is if we determine with a caller whom we've de-escalated and is feeling better, but still is not going to be safe on their own and needs to be transported to an urgent care facility or stabilization center, that we can call for that. If it's a medical emergency, let us call LA Fire directly and request ambulance services, right? We can't do that right now. Right now, everything needs to go back to law enforcement as the middleman. So that's a gap we still need to work on. And then finally, we definitely need more follow-up care. But I want to share with you that at Didi Hirsh, we have a fairly robust program already in place. 3 tiers. We offer short-term follow-up. This can be as short as 15 minutes after a call has ended. Um, and this would be really high risk situations, right? Where a person maybe has the means available, um, and they're really struggling with suicidal thoughts. But the last thing they want to do is go to a hospital. At least they're not ready for that in that moment in time. But they tell us I can be safe for the next 15 minutes, 20 minutes, half an hour, whatever. Um, we're going to set a follow-up call with them in that short amount of time, because sometimes what is needed after a really intense call is some processing time. And maybe when we call them back in 15 minutes, either they feel better and able to stay safe longer, or they recognize, you know what, I do need more care. And that helps us avoid involuntary intervention. And it also wards off, or I would say encourages future help seeking behavior. Because if we don't do that, if we need to break confidentiality and rescue somebody against their will, the next time they're in crisis, they're much less likely to reach out for help. So this is very important for us, and it's worked very well. Standard follow-up care typically is between 24 and 72 hours later. And then we also have extended follow-up care, which is kind of like a mini case management. So there's multiple calls over a period of time, could be anywhere from a week to 2 or 3 months. Um, and we do that primarily for individuals who have been hospitalized for suicide attempt or suicide ideation and have given their consent for us to follow up with them. But some callers also fall into them. For that though, we want to do way more follow-up. I love follow-up. I think it saves lives. And it would be great if eventually we could do follow-up with mobile response clients, with co-responder team clients. We have an amazing program called Survivors of Suicide Attempts, or SOSA, and have some wonderful peer facilitators there. And we would love to involve them in providing follow-up care, really through the lens of being a peer, right? And then finally really do more long-term evaluation and ensure linkage for all the follow-up that we do. So also gap to close, but well on our way.
I have a question. I don't know how involved you were, and maybe not at all if I caught on properly, in the pairing of the clinician with the peer. That's something that we are looking at doing or will be doing on our mobile crisis response team. And some of the clinicians are having some anxiety about that. And, what if the situation is, not a good situation for a peer to be in? It's kind of what it boils down to. Or what if they have a different feeling about what we should do than I do? And I, as the clinician, say they meet criteria for hold, and the peer, the client perhaps doesn't want to go in, and the peer is aligning with the client or consumer, or whatever term you might use. So I don't know if you were involved in that at all and have any experience, but I'm curious to hear how it went.
So at the county level here, at least they're working on guidelines around that, right? And I believe that there are efforts underway for best practices with this, and there's various models out there. I know that at the early things that I have seen is that ultimately there is the clinician is actually the person in charge, right, on the team itself. It doesn't necessarily mean that they're always right either, but you do need to build in that structure, and I think that's extremely important. And that's also, as I mentioned several times, there's such a workforce issue right now. If I am, as a clinician, am able to provide telehealth in a private practice from the comfort of my own home, right? And maybe even make more money doing that. Why would I choose to be on 24/7, call, being on call and going into, um, but volatile situations? It takes a special kind of, person to be able to do that. And so I think that's really important to acknowledge that as you build out these teams, knowing that the clinicians that are part of these teams, um, they have a lot of passion and also a lot of experience probably already coming into this. And if they don't have it, they'll rapidly build it up. So I think it's important to set guidelines around that and acknowledge their expertise in this. But this is actually kind of new in our field. There's not a lot of models out there that have been in existence for a very long time. So it'll be interesting to see how it develops. But yeah, it's a great question. Absolutely. The technology platforms that we need to use or that we want to use that are under development, and there's different things out there indeed. But this issue of having real-time data and access to all of these components, where are the teams? What is the situation that they were previously involved in? Do they need some extra time to recover from that? Are they fully ready for the next call? And are they in the best location to respond to this situation that may take them 2 hours across the county to get to, or is it going to be lower priority and in the area where this situation is happening, there's no crisis beds available? All of that stuff, technology is extremely important. We are working with CalOES, so all the centers together, and with the help of the 90-Day Technical Advisory Board in California, are working through all of that. If any of you are interested in the work that's being done there, I encourage you to check out the public meetings that the Technical Advisory Board has. And there's a number of working groups available that are addressing these things as well. Like, for example, 911 to 988 interface, right? What I can tell you is that the problem right now would be, so LA County wants us to expand 911 diversion, include other police departments. We're saying, well, the problem with that is we cannot have like a list of 15 high priority lines, and add that into our system. The technology needs to be in place first, that or the interoperability between 911 and 988 systems is a lot better. So those are some of the things that we're working on. And I think it is important to look at what works for some counties. I do not believe in reinventing the wheel. I don't know why the decision was made to build our own system, our own platform. It's challenging for the centers as well, because we all use our own systems that we love or not love, and we're trying to work together as a network, just between the 988 centers. I think that there's great systems out there that we can absolutely use, and I foresee the problem is if Didi Hirsh services Orange County and LA County and San Bernardino County and Ventura County, and then each county says, well, this is what we're using for our system, and I know that CalOES came up with something different, but we don't like to use that, then we're still stuck in the same position, and that's the problem. So I completely agree with you, and we'll do our best to advocate to make sure that the interoperability becomes true interoperability no matter where you are in our state. And I think that's extremely important. Yeah, thank you for raising that issue.